So our next speaker that I would like to introduce is Dr. Satish Singh. He is a newly minted associate professor. He's a gastroenterologist who works both at Boston University, both in our School of Medicine and in the College of Engineering, and at the VA, which, by the way, is a very interesting place to partner with clinicians if any of you are interested. I've asked him, he works with a collaborator of mine, and I think you're going to find his presentation on colorectal cancer and screening with new technology particularly interesting. So, Dr. Satish Singh.
Good morning. Everyone can hear me okay? Good. So I was asked to speak about colorectal cancer. And I think what we're seeing in the realm of colon cancer prevention is an increasing convergence of medicine and engineering, where medicine is the science of diagnosing, treating, or preventing disease and other damage to the body or mind, where engineering is the application of scientific and mathematical principles to practical ends to design, manufacture, and operate efficient and economical structures, machines, processes, and systems. And the explosion in mechanistic understanding of disease is really driving the disciplines ever closer. The outline or learning objectives I have in mind are to give you some background on CRC, or colorectal cancer, and I'll refer to it as CRC herein. The clinical features, screening, prevention, and endoluminal treatments. Addressing areas of need, if I have time, towards quality, efficiency, and throughput in prevention. Seeing more and biopsying less, which I think is kind of where the trends are. And more definitively removing neoplasia, which includes cancer and precancer. So a bit about background. Where is the colon and what does it do? Well, anatomically, it's defined as where the small intestine ends in the cecum down to the anal canal. All the blood from the colon, like all of the viscous organs in the abdomen, all the blood that flows through it then goes to the liver. And the liver is actually like a sieve. And so blood from the bowel goes in through the portal vein, it's called the portal vein, into the liver. Lymph drains to the pericolic nodes. There's lymph nodes that are arrayed. Now, you should understand that the colon is not essential to modern life, as many of you may know people who have colostomies, they're absent a colon. But it is crucial for a normal functioning life. And you have to think about it in terms of evolution, I suppose, in that it's probably more a biological remnant than anything else, where it was a fermentation compartment for poorly absorbed complex carbohydrates. And what happens is the bacteria ferment those things that we can't digest, and we absorb the byproducts, which are called short-chain fatty acids. So ultimately, in traditional societies and pre-industrial revolution, we were absorbing about 12% of our calories through this short-chain fatty acid pathway. But more importantly for us now, it really is a water salvage pathway. It is actually what prevents us from walking around, I apologize, but with diarrhea all the time, because you have subclinical changes in the way that you handle the water that's in your gut, and you're often changing the amount of fluid that gets sent to the colon. Well, your colon is actually able to upregulate its water salvage capacity such that you're not having diarrhea, and many diarrheas are, as a result, subclinical. Okay, so what is the structure of the colon? Well, it's arrayed as an organ per se, and within the organ, there are substructures. So first, there are the subsegments. We term the right side of the colon the ascending colon, the part that crosses across the abdomen, the transverse, and then the part that goes down the descending, which then goes into the sigmoid, which is S-shaped, into the rectum. So among these subsegments, there are mild functional differences, but ultimately it's just a large muscular tube. But more interesting is the lining of this tube. It's a monolayer, a single layer of cells, epithelial cells, but they are super specialized in that certain ones that are towards the fecal stream, more superficial as we say, are then interspersed with these pits or wells that dive down deep. What you should know is that the stem cells that repopulate this whole epithelium every 72 hours or so exist in this crypt compartment and divide, and the cells are sent in towards the fecal stream and then eventually shed. So so this epithelial layer is invaginated into what's called the lamina propria. That is a substance that contains matrix proteins as well as fibroblasts and immune cells. Below that and into it a bit are a vascular network and a neural network, and underneath that is longitudinal and circular smooth muscle that mediate contraction. So what is colorectal cancer? Well, generically, cancer is the uncontrolled growth of cells in the human body with the capacity to migrate from the original site, would spread to distant sites, that can result in organ damage and death. And here's an endoscopic view of an advanced colon cancer. Here's a radiographic. In the old days, we used to do something called a barium enema. I'm not sure if anybody does them anymore. So where does colorectal cancer start? Well, it actually arises from this epithelial monolayer that I was talking about. As I said, the lining normally turns over rapidly, so it's a rapidly dividing cell population, and it is shed every 72 hours or so. 95% of colorectal cancers begin as benign precancerous polyps, and I'll go into that in a bit. So this is a picture of a polyp here. Statistics about colorectal cancer. Well, cancer is the second leading cause of adult death in the US. Cardiovascular is the first. Colorectal cancer is the third most prevalent cancer and the second leading cause of cancer death. There's 150,000 new cases of colorectal cancer diagnosed each year, representing about 10% of cancer cases. And it's estimated there are 52,000 deaths a year from colorectal cancer, which is 17% of all cancer deaths, that is. But that's a number that thankfully is falling due to what I'll be talking about, which is screening and prevention. You should know that about 5% of people, if we don't intervene, will end up developing colorectal cancer in their lifetime. So that's the overall lifetime risk. And this is, of course, a Western number. Eastern populations, it's very different. It actually, interestingly, cancer of the GI tract is more related to the upper tract than the lower tract in Eastern societies. So the great thing is that colorectal cancer is largely, if not entirely, preventable. It's an unusually happy and I think increasingly happier story. Screening does work. It has actually caused a decline in overall cancer mortality. And this is largely, the overall numbers are actually mostly due to the fact that colorectal cancer is successfully being prevented by colonoscopy. Now, while colonoscopy is expensive, the actual cost is quite cost effective because it's a dual screening and risk modifying intervention. That is, you're going in to make a diagnosis, and at the time of the diagnosis you can actually intervene to remove precancerous tissue and prevent that cancer from ever happening. So when you look at overall analyses, colonoscopy costs about $20,000 per life year saved, which is actually on par with mammography. So the clinical features. There's early and late. Early clinical presentation is what I call the 3 Bs. Bleeding, so there can be frank bleeding, spotting, hematochezia, which is bleeding from the rectum. There can be occult bleeding, and that is bleeding that's inapparent visually or put to the patient. But with chemical testing for hemoglobin in the stool, we call this fecal occult blood testing, it can be picked up. The second is blockage. There can be a change in bowel habit, largely constipation, although diarrhea can also occur, and a change in stool caliber, and this is due to the tumor or mass impinging on the luminal space. Partial obstruction can also be manifest. And third, bupkis, which is the most common. It is a silent killer, and therefore it necessitates us to perform asymptomatic screening. The late features include anemia. It's typically or classically an iron deficiency anemia that's due to chronic blood loss from this lesion that's leaking. Fatigue can be due to the anemia and or tumor factors that are elaborated that actually change metabolism. There's associated weight loss, probably from a catabolic state, catabolic meaning that you're breaking down. Again, as I said, complete or partial colonic obstruction, abdominal pain, and unfortunately liver function abnormalities, which are a premonitor of a poor outcome because That typically means that the cancer has spread to the liver. The risk factors for colorectal cancer are first age. And we're talking here about the sporadic colon cancer. Sporadic colon cancer is what most of us are at risk for. It's the accumulation of what we call somatic mutations over our lifetime. And this is in the absence of a family history or a genetic predisposition. This explains about 90% of these occur above the age of 50, hence that's the trigger point for us to start to screen people at age 50 who are asymptomatic. And this explains about 75 to 80% of all colorectal cancers that we see. The risk factors along this line include metabolic factors. Diabetes puts you at higher risk. Obesity puts you at higher risk. Insulin resistance, the relative risk about 1.5. Toxic insults that we expose ourselves to on a regular basis, including alcohol, tobacco, a high-fat diet, in fact, red meat, and a history of X-ray therapy exposure. So that's sporadic colon cancer. Then there's people who have a history of colon cancer themselves or in their family. This explains about 15 or 20% of colorectal cancers. So this is not technically sporadic, though it may fall as a subset of the sporadic category. There's genetic causes for colorectal cancer. These are germline. These are written in your genes, and they're in the genes of every single cell in the body. These are the classical inherited polyposis syndromes, which include familial adenomatous polyposis, an attenuated version of it, hereditary non-polyposis colorectal cancer, which is a flat adenoma cancer, and MYH mutation associated polyposis. These all together, they're interesting, but they explain anywhere from 3 to 5% of the colon cancers we see, so it's a specialized area of interest. And finally, chronic inflammation, patients who have inflammatory bowel disease, which includes ulcerative colitis and Crohn's disease that affects the colon, are at an increased risk of developing colorectal cancer with a relative risk of 4 to 20-fold, depending on who you read. But what you should understand is that inflammatory bowel disease is fairly rare in the population, and that even though the risk is elevated in terms of a relative risk, the absolute risk is still quite low, being under 1%. So we don't see very much of inflammatory bowel disease-associated colorectal cancer. The hereditary colorectal cancer syndromes, I did mention, you're at risk of developing numerous polyps at a young age with a very high risk of developing colorectal cancer early, and as well as other cancers, especially if there's a germline mutation. There's the FAP, familial adenomatous polyposis. These patients develop 100 to 1,000 polyps starting in their teens. Colorectal cancer is actually certain by their 40s without having their colon and rectum removed. They're also at risk for thyroid, gastric, duodenal, and bile duct cancers that start as adenomas. And this is due to an APC gene mutation. There's an attenuated version, which is a milder version as well. It's a bit more difficult to manage because it's often not clear that the patient actually has this over sporadic. Non-polyposis colon cancer or flat polyps in cancers usually occur in the right colon in patients who have this gene defect and in their 30s and 40s. They are also at risk for uterine, gastric, ovarian, ureteral, and biliary cancers, and it's due to a defective DNA mismatch repair gene and microsatellite instability. Finally, MYH-associated polyposis, more recently understood to be a real entity, 10 to 100 polyps developing around age 40 with a high risk of developing colon cancer, again, a defective DNA mismatch repair, the situation. Okay, so what are the protective factors if you are at risk? Well, diet and fiber have been shown, or at least in population studies, are associated with a lower rate of colorectal cancer. It seems that the more fiber that there is, less contact time and maybe actually scavenging toxins from the fecal stream. Folic acid, calcium, magnesium have been associated. Aspirin, you may have seen this in the news. It's both anti-inflammatory and growth inhibiting and may prevent a cancer on that basis. Non-steroidal anti-inflammatory drugs include ibuprofen. These also seem to prevent the development of cancer. Hormone replacement therapy, physical exercise, ideal body weight, and clean living, absent toxins, and vegetarianism. So a bit about the staging, prognosis, and treatment. So we have to, in fact, stage a cancer before we can decide how to treat it. So stage 0 is the earliest stage. It's restricted to the innermost lining or the mucosal layer I was talking about. One can perform colonoscopic polypectomy to remove the tumor and the surrounding tissue. If there's a larger lesion, a surgical resection can be performed. It may require an anastomosis, that is an unhooking and a rehooking up, to remove the diseased part and reattach the healthy tissue. Removal in stage 0 is considered curative, and there's a greater than 95% 5-year survival in this condition. Stage 1, also termed Dukes A, is a cancer that's spread beyond the mucosa to the second and third layers at the inside wall, but not to the outer wall or beyond the colon. Treatment is surgery to remove the cancer in a small perimeter. Additional treatments are usually, adjunctive treatments are usually not needed. So aggressive removal is usually curative, and the 5-year survival is still quite good at 93%. Stage 2, or Dukes B, is a larger lesion extending through the muscular wall, but not into the lymph nodes. Treatment is surgical removal and or adjuvant immuno or chemotherapy with a 5-year survival of 78%. Stage 3, or Dukes C, is a cancer that's spread outside the colon to one or more nodes. Treatment is surgery to remove the tumor and all involved nodes, plus chemotherapy, and now the 5-year survival drops to about 64%. And stage 4, Dukes D, is a cancer that's actually spread outside the colon to other parts of the body, including liver and lungs. The treatment is largely palliative, with debulking and anastomosis to keep the bowel open. Chemotherapy, as well as clinical trials of new drugs, and radiation, but I want you to know that the 5-year survival then plummets to 4 to 8%. So it's really important that we pick up colorectal cancer early, because the outcomes are so good if we do. So as I said, the goal is prevention. It is achievable now with the advent of flexible colonoscopy. Because we understand the biology of colorectal cancer, and there is a sufficient lead time, which actually it takes about 10 to 15 years for a typical sporadic colorectal polyp to become a cancer if it's going to do so. There's sufficient lead time, so we can prevent colorectal cancer by screening for these polyps and removing them. The detection and removal of precancer in early stage lung cancer is our goal. So what are screening approaches? Well, first, should we even screen for colorectal cancer? Before we decide that we're going to screen for a disease, we have to meet certain tenets. Those include that there's a significant burden of asymptomatic disease in the population, which I think I've made the case there is. That there's a preclinical stage that's detectable and quite prevalent. Again, I think that's true. That early detection will improve the outcome and mortality with an acceptable morbidity, meaning that it prevents deaths and it does so in a safe manner. Yes, I think that's the case. That it's acceptable to the population, inexpensive, and relatively accurate. So here may be where there's a bit of controversy. Acceptability is a personal decision. Expense, again, I think I've made the case before that it might be no more expensive than mammography in toto. And accuracy, it certainly has. And are there effective treatments available for diseases detected at the various stages? And I think, again, the case can be made that the answer is yes. So colorectal cancer is preventable. It's a mucosal disease. It starts as a polyp, evolves over 10 years. Polyps are relatively easily detectable and resectable. So if they're removed, it markedly decreases the risk of colorectal cancer. Everyone understands that. So there are a variety of strategies that have been advocated by the American Cancer Society and other professional societies. So these options start at age 50, because that's when the prevalence of the disease starts to go up. And the options include home fecal occult blood testing every year. And that's a stool test that looks for blood leakage from a lesion that's likely to be there. Sigmoidoscopy, which is like a 1/3 colonoscopy. And what you say, well, why would you do that? Well, the reason is that it's much lower cost. It doesn't require sedation, and it doesn't require a full bowel preparation. We're going to dive a bit more into this in a few slides. Colonoscopy, this is recommended every 10 years. CT colonography, or what you know as virtual colonoscopy, advocated every 10 years, or any combination of these tests. Again, professional societies vary in their recommendations, but I think at this point, really, the preferred approach is colonoscopy, as it gives you one-stop diagnosis and prevention by the ability to clear precancerous adenomas. In fact, primary care providers overwhelmingly recommend colonoscopy, about 95% of them, and or FOBT. Only a small minority recommend flexible sigmoidoscopy at this point. And this is older data, but there was actually an era when primary care providers did flexible sigmoidoscopy. 4% of them did it themselves. Our problem is that compliance with CRC screening is actually abysmal. Though major public awareness campaigns have increased the demand for colorectal cancer screening, compliance remains poor, such that more than 50% of average risk Americans above the age of 50, and that's about 40 million people, have yet to be screened by any modality. So, there are a variety of reasons for that, but I think a large part of it is the perception that colonoscopy is invasive. People do not want to perform the bowel prep. But I think as time goes on and as education initiatives penetrate into the population, people do understand that it might be something that they only have to do once every 10 years, but it could save their life. So let's just talk about each of the modalities for screening. Screening via stool assessment is certainly the most acceptable to patients because it's the least invasive option. There's fecal occult blood testing. This is the most widely used test. It's a test that performs a peroxidase reaction on a piece of filter paper, effectively, to look for the presence of hemoglobin. It's inexpensive, but it really only shows a modest reduction in mortality from colorectal cancer because the sensitivity and predictive value are suboptimal. It's only about 10% for advanced lesions. There are new fecal immunochemical testing kits that use antibodies to human hemoglobin that are actually seeking to improve adenoma detection and to improve the false positive rate. Sensitivity has been published at about 25 to 72%, specificity 70 to 97%, versus fecal occult blood testing, where sensitivity is 9%, specificity 96% for standard FOBT, at least in that same study. Fecal DNA analysis has been advocated, looking for genetic mutations that are associated with colorectal cancer. Their performance has shown marginal increase in sensitivity, about 18%, offset by a very high cost at about $700 per sample. So the jury's out. I think stool assessment is interesting. It may be the wave of the future as its performance improves, but for now, it certainly it doesn't make the grade. And remember, this is simply a diagnostic platform that every time this comes back positive, it's going to trigger the need for a colonoscopy. So it's not a one-stop option. Virtual colonoscopy or CT colonography is a variation on air contrast barium enema. That was the test that had been around for 30 or 40 years with the insufflation of barium up the rectum in 2 phases, a solid column phase with the fluid, an X-ray taken, and then the evacuation phase with the insufflation of air such that you could see the lining highlighted by barium. But studies have shown that it's clearly inferior to colonoscopy, so it's pretty much been dropped as a screening modality. However, screening CT colonography has generated renewed interest in the radiological approach. What it does is it basically takes that air contrast barium enema and reconstructs it in 3 dimensions so that luminal features are highlighted by a fecal tag. Patients perceive it as being more accessible and less invasive than colonoscopy, although I'm not sure that's true. I've heard many of my patients say that it's a lot more uncomfortable than colonoscopy because they're not sedated and a lot of air is being insufflated into the rectum. Initial studies have shown excellent sensitivities. However, more recent multicenter trials show that performance is somewhat lower, the sensitivity of 55% for polyps greater than 1 centimeter, and those are the ones we want to worry about. There are other limitations of virtual colonoscopy, that even with the improved performance, there are certain barriers as a screening tool. In most studies, a third of the patients still harbored polyps that required a colonoscopy. And as such, even with optimistic assumptions, CT colonography is not superior to colonoscopy and would need to be priced at below $300, which it's not, to be cost effective. The other problem is that the lowest detection limit that there is for virtual colonoscopy is only 5 millimeters, and it certainly misses lesions that are flat. So, you know, these are issues that are certainly addressed by colonoscopy with a lower visual limit of, you know, 1 or 2 millimeters. CT colonography still also requires a bowel preparation, and as I said, that is probably the major screening barrier for many patients. It's uncomfortable due to air insufflation without sedation, and patient satisfaction surveys say that virtual colonoscopy is actually not preferred over colonoscopy when patients who had both have been polled. Further, using CT as a screening modality engenders concerns about ionizing radiation with the risk of future cancer and the handling of collateral findings, things that you find that you weren't even looking for. As a result of all of these factors, the Center for Medicare Services a few years ago actually denied coverage for this virtual colonoscopy as a screening modality because of insufficient efficacy data in patients who are above the age of 65, which is their population, I should add, and where these patients have a higher prevalence of polyps just by virtue of their age. So it's not the best test for people certainly above the age of 65. Flexible sigmoidoscopy. It's an increasingly less performed endoscopy of the distal 1/3 of the colon. The last time that I've been able to find data on how many have been done in a non-endoscopy unit setting, about 2 million were performed in 2002. And what this is based on is the principle that if you find polyps in one part of the colon, it actually engenders a risk that you're going to have them elsewhere. And that's called actually the synchronicity of lesions, that synchronous lesions are going to be present. And that probably reflects the fact that when you see a polyp, it's an indication not of the fact that the tissue where the polyp is sick, it's that the whole organ is sick. So if you find these sporadic areas or foci of disease, then you're likely to have them elsewhere. And we call this the concept of the field effect, where there's a defect in the organ itself. So why this might have some advantages over colonoscopy is it doesn't require an oral preparation, no sedation is required, and in fact a non-gastroenterologist, a non-surgeon can perform it. It has been prospectively demonstrated to decrease colorectal cancer deaths, but it has a poor sensitivity. You can well imagine that would be the case because you're not looking at the entire colon. So an editorial in the New England Journal actually said it might be the same as doing a mammogram on one side, which it effectively is. 60% of advanced proximal lesions will not have a sentinel distal lesion, so this is a problem. And the positive predictive value of small adenomas that are found is marginal at only 6%. Thus, it's not the best or most cost-effective test, but it's clearly better than no test at all. And so several closed sort of systems like the VA actually still use flexible sigmoidoscopy as a screening option, and people actually opt for it because it's less invasive. And now into colonoscopy. Colonoscopy is the use of a flexible, steerable scope. It's about 6 feet long that is negotiated up and through the colon to the cecum. And you might think, well, it's very simple. You just take the tube and you push it. But in fact, what you're trying to do is push a rigid scope through a tube that is basically floppy. And as a result, nothing is really ever straight, and when you push forward, you're transducing forces in the forward direction, but trying to make a turn is difficult because you're just still pushing forward. So it takes a little bit of skill. I'm not saying that it's not doable. I mean, thousands of people are trained to do it, but it's not trivial, and operator features are actually very important. Operator competence is very important in the outcomes, and I'll get to that. So prevention. Optical colonoscopy, it's considered the gold standard for detecting colorectal cancer and polyps. It permits us to screen and treat. Our edict is to leave no polyp behind. Both large cohort and randomized studies have shown that the clearing of adenomas by colonoscopy with polypectomy prevents up to 80% of colorectal cancers. That's pretty good. Now, what we do with that information is there's a series of post-polypectomy guidelines that are based on risk tables, and these are based on the findings at colonoscopy. Your downstream risk of developing colorectal cancer and needing another surveillance exam is stratified based on the number, the size and the histologic grade of removed polyps. And size does matter here in that small polyps carry less cancer risk than large polyps. Certainly ones above 1 centimeter are termed advanced cancers, and advanced polyps, and up to 10% of them can actually harbor cancerous cells in them. And so here's a snippet from the risk table. But as you see, colonoscopy is not only preventing cancer by removing precancerous tissue, but it also then, based on the findings, allows you to plug your patient into the next appropriate screening interval to prevent cancer from developing subsequently, which we call interval cancers. And now, so the issue is that so that's great. I've been talking about adenomatous polyps, but I need you to understand that there's a little bit of a problem here in that there are two predominant polyp types that we come across. And for simplicity's sake, let's just say half the people we colonoscope have polyps. Half of them will have polyps that are of no clinical significance, and we call those, again, simplistically, hyperplastic polyps. And the other half will have the ones that proportion will evolve into cancer, and those are known as adenomatous polyps. And this adenoma to carcinoma sequence occurs over 10 to 15 years. As I said, an accumulation of genetic hits that eventually causes the development of cancer. So the adenomatous polyp sequence is here, and here's a hyperplastic polyp. Ultimately, the small ones have low malignant potential. But the problem is that at colonoscopy with white light, it's not easy to tell. In fact, it's virtually impossible with accuracy to be able to distinguish the two polyp types. So 30 to 50% of the polyps that we take out are really are of significance. The rest are not. And it's the early removal of the precursor adenomas that prevents colorectal cancer, not the hyperplastic polyps. And this is the basis of prevention, as we've been talking about. Now, one other thing I want to throw in there so I'm complete is that I can't be completely, make a complete blanket statement about hyperplastic polyps being insignificant, because there's another pathway of carcinogenesis called the serrated pathway. And that's a different series of mutations that can actually occur in small hyperplastic polyps on the right side of the colon. Again, it's a problem with DNA mismatch, with microsatellite instability in DNA. Can be inherited, as we've talked about, but acquired is what I'm talking about, the sessile-serrated or hyperplastic polyposis pathway. It's impractical for us to test every polyp we take out genetically, and there's a fairly low prevalence of these polyps, so that clearing of all these polyps will still prevent colorectal cancer. So it's a little bit of a splitting hair situation, but I didn't want you to say to people, oh, hyperplastic polyps are completely benign, because there is a small subset that are not. Endoluminal treatment. So we find polyps and we take out polyps in a variety of ways. And for polyps that are 5 millimeters and smaller, we'll use tissue Sampling-Forceps, which are basically a simple scissor design actuated by a cable to pinch and avulse polyps. 90% of polyps that are detected are less than 1 centimeter, and 80% of those are removed with pinch biopsy forceps. So it's the dominant tool for polyp removal. Here is a video of a fairly large polyp, actually. We'd call this an advanced adenoma. That's being removed by snare electrocautery. It's a nitinol wire loop. The patient is grounded and a current is applied. So it's a bipolar coagulation and cutting that removes the tissue. It leaves a mucosal defect, which the cautery prevents bleeding. And then subsequently, because these chunks are so large, they cannot be pulled through the scope. You actually have to grab them with a basket device and drag them out of the patient. For smaller sessile polyps that are difficult to take out and to ensure complete removal, there's a technique called saline-assisted endoscopic mucosal resection, or EMR. Again, it's used with large sessile and flat lesions. Injection of fluid separates the tissue plane, the submucosa, from the muscularis, and this is the injection. It raises this polyp up, and basically creating a pedicle that you can snare and cut with assurance that you've got the widest margin, the most appropriate margin possible. There's a system called cap-assisted EMR. Here, a flat lesion is also turned into a polypoid lesion using suction. So a cap is fitted onto the scope. There's actually a wire that comes down and a loop that's in a lip around the tip, so that when you suck the polyp into the tip, this loop can be closed and a piece of tissue can be avulsed and dragged out. Can be sectioned and dragged out. So what are our areas of need and what is some of the work that's been going on towards addressing them? Or there's got to be a better way. Well, first, quality and access to screening colonoscopy is a big problem, and this comes perhaps more on the population level than on an engineering level. Colonoscopy has in fact been found to be less protective than expected due to these pervasive quality issues. Large studies have found colonoscopy and suboptimal exams due to a few factors, and these have again been shown in population studies. The time you take during withdrawal of the scope to inspect the mucosa makes a big difference in your sensitivity as an operator. The time of day. Having your colonoscopy in the afternoon, you're going to have a lower chance of having all of your adenomas found. Inadequate bowel preparation, and that's intuitively obvious because we don't have a way of seeing through poop. If someone can invent that, that'd be great. And there's limitations of the forward view with white light. Excuse me. As I'd shown in previous pictures, there are these haustroy folds, and we are looking at the front of the folds, but we're not looking at the back of the folds, and it's possible there's polyps on the back. There are operator factors also that include experience, training, age. These all lead to a low adenoma detection rate. The problem is that the lowest performers in studies, in fact, bestow a 12-fold increased risk of death from colorectal cancer after colonoscopy. So that was quite striking, and I think it tells you buyer beware. You should know what your adenoma detection rate is of your endoscopist before you undergo colonoscopy. In fact, there are moves for providers to be tracked and to maximize their adenoma detection rate as a quality measure and to provide this data to prospective patients as well as to payers, because payers want to, if they're going to keep you on a panel, you have to meet a certain performance standard. The other problem is the missed adenoma. Missed and incompletely resected adenomas have been a long-standing and well-recognized problem. In tandem studies, meaning a colonoscopy followed by a colonoscopy by another operator, yes, I know some people actually do sign up for that, up to 27% of 1 to 5 millimeter polyps, 13% of 6 to 9 millimeter polyps, and about 2% of larger than 1 centimeter polyps can be missed even with the best conditions. Also affecting efficacy are increasingly appreciated poorly visualizable flat neoplasms. These are the flat polyps I was talking about. And again, about 10% of them can harbor advanced features. So our goal is to see more and to biopsy less. Colonoscopy is also, while being applied as a screening modality, was really designed as a minor surgical procedure. So it's a resource-intensive undertaking. There's about 14 million colonoscopies per year in the United States. That's huge. There's a huge amount of resources that are really not available for widespread deployment for screening. In fact, the demand for average risk screening alone, this is just the screening, outstrips the supply and would necessitate deploying 30,000 more gastroenterologists beyond the existing 11,000 to meet the demand right now. And this projection does not include the follow-up procedures that are going to result from the screening colonoscopies and the shorter intervals that will be recommended because patients have advanced lesions. So technological and process improvements are needed at many levels, especially for detection of polyps. Societies have called for real-time histology, that is to be able to make a call on tissue being normal or abnormal, to more efficiently, and in situ that is, as you're doing the procedure, to more efficiently and selectively manage polyps, diagnose and discard, for example, if they're of no significance, and obviate multiple passes of the scope for retrieval of inconsequential polyps. As I said, larger polyps have to be dragged out. So areas needing improvement include quality, efficiency, and throughput, the detection of lesions, that is improvements in sensitivity of adenomas, the correct classification of tissue, and improvements in specificity of the diagnosis, and the definitive removal of neoplasia so that recurrence is not a problem. So I'm going to march through some of the approaches that have been looked at, proposed, and tested to improve. How am I doing for time?
You're fine,
okay. So the first and oldest is something called dichromoendoscopy, and what this is a methylene blue dye or other vital dyes that are sprayed on the mucosa to in fact give you improved reliefing of the mucosal texture. It enhances the structural detail by this reliefing, but it does not enhance the vasculature. Again, this is to solve the problem that if a polyp is seen, we don't know what histology is. Well, we can combine this spray technology with optical magnification and assess something called the Kudo pit pattern. Kudo is from Japan, and he described pit patterns and as predictors of the presence of neoplasia. And with training, accuracy can be as high as 90%. But the issue is that it's extremely clinically unfriendly, cumbersome. There's a steep learning curve. You need more than 300 cases to be proficient. And as a person who's used it, you should never wear a white shirt when you're doing this type of procedure. So actually, in 2004, a concept came up of an alternative to dichromoendoscopy. Why not try to use light to highlight mucosal texture? And so, in fact, Judah Folkman, who came up with the idea that cancer is angiogenic, was really the seed for this approach. Because dichromoendoscopy showed structure, not vasculature, the thought was that if we could, well, not me, if groups in Japan who came up with this could use narrowband light, one could then enhance features that were not just mucosal but vascular. So two of the technologies are termed narrowband imaging. That's Olympus's technology. And multiband imaging. Narrowband imaging is actually the illumination with blue light, and multiband imaging is actually a digital filtration so that blue wavelengths are looked at on the detector end. Both are now widely available as push-button toggle features in high-resolution endoscopes. So the narrowband illumination, the principle is that it illuminates with blue and green wavelengths that are related to the hemoglobin absorbance peaks. Structures, therefore, that are rich in hemoglobin, i.e. vessels, will appear darker and more contrasty, and thus the vascular patterns are enhanced. There's a little bit about the differential wavelength penetration. The blue hits more of the superficial vessels, as you know, and it gives us a color that's browner than the green, which hits the more submucosal vessels, and they appear a cyan color. So here's a white light endoscopy image of a flat lesion, which, as you see, is quite subtle. You barely can see it. When you click on narrowband imaging, you can see the normal cyan vessels and then the brownish vessels that are in intrapapillary capillary loops. And these are due to the angiogenic, more superficial microvasculature. This also works on larger polyps. There's a sessile polyp where it's difficult to tell what the texture is of the mucosa and the vascularity, but when you use narrowband imaging, the vessels pop out and the mucosal features do. And this is what the Kudo pit pattern is based on dichromoendoscopy. And as you see, they're fairly closely accessible. High definition CCDs have also improved outcomes. And there have been attempts at overcoming the limitations of forward view. As I've talked about, when you look forward, you can't see behind a fold. Well, there are scopes that will curl on themselves and scopes that will actually go through the scope and curl on itself and allow you to look on the backside of folds, and have been shown to improve adenoma detection rate because you're seeing more mucosal area. You may have heard of the PillCam. There's a capsule called PillCam colon. This is a CMOS imager with light source on both sides that allows you to take images as the capsule passes over a several hours period. It's swallowed with a glass of water. You do need to have a prep beforehand because, again, we still haven't solved how to look through poop. So, again, as I said, LED lighting, cameras at each end, captures about 4 frames per second for up to 10 hours. Upon completion, the recorded images are downloaded to an unfortunate individual who has to interpret all those images for review. The bottom line is that PillCam evidence is so-so. There were issues with pills getting hung up in patients. And again, in terms of the barriers to adoption, you still need a preparation, and you're still going to need a colonoscopy if you find something. There's issues of preventing recurrence after endoscopic mucosal resection, and endomicroscopy has been touted as a solution. As I've said, definitive resection using colonic EMR is increasingly performed as part of prevention towards curative resection of flat sessile adenomas and stage T1 lesions. It's preferable to surgery given lower cost, morbidity, and mortality. It's typically an inject and cut approach where unblocked tissue is removed and permits histopathological assessment of the adequacy of resection over ablative approaches where you simply destroy tissue, you don't know what you've got. Problem is that these lesions that are large recur in 21 to 46% of patients, and aggressive surveillance is pursued. It's questionable for more invasive lesions and discouraged for ones that you might think are advanced, which don't lift when you inject them. So in situ histology in real time has been called for to better reveal incomplete resection, guide therapy, and limit recurrence. It's based on real-time information. The EMR could be extended or supplementarily ablated. The result will be fewer follow-up procedures, improved cure, and lower costs. And confocal laser endomicroscopy for real-time histology has been applied to this use. It's a dedicated endoscope or a catheter probe that's equipped with a laser scanning confocal microscope system where the confocal aperture is scanned in 2 dimensions to construct an image in one focal plane or an optical slice that's en face. The autofluorescence in the mucosa is actually too low for it to be useful, and so it mandates the use of an IV fluorophore, which in the United States is fluorescein sodium. In Europe, they use a dye called acraflavin. It's a flavonoid which binds DNA, and as a result, it's mutagenic, but it certainly permits superior assessment of dysplasia because most of those features are in the nuclei. Here's the Pentax iteration of the scope-based confocal, and this is the Mauna Kea Technologies probe-based confocal. They have different performance characteristics, the endoscope-based being able to be moved into the z-axis, so volumetric images can be created, whereas the Mauna Kea system has no moving parts on the distal objective end, so it's a single slice about 70 microns into the tissue. Field of view is different and resolution's about the same. Major difference is that Mauna Kea system permits you to make dynamic pseudo videos at 12 frames per second. So in fact, here's a normal mucosa. You can see the rosettes and this H&E, hematoxin eosin slide from histology. And here's the confocal image. You can see the crypt openings, the goblet cells. Here's a hyperplastic polyp with star-shaped crypt openings, and you can see the star-shaped crypt openings in this image, as well as a hyperplasia of goblet cells. Here's an adenoma or precancerous tissue, and you can see darker tubular structures. And finally, cancer. You can see the dye is leaking, the black cells that don't take up dye, and the overall architectural disarray, which are, again, histopathological features of cancer. Confocal has been quite accurate for neoplasia classification with sensitivities and specificities in the high 90s. Combined with a red flag technique, it's possible to actually find dysplasia and classify it. So post-EMR, these scars are what are the results. And this is just a clip put in place that's still there from a previous scar. So this is actually a benign scar that doesn't have any recurrent tissue, and this is a neoplastic scar that has recurrent tissue. And if you use confocal, you can see a largely acellular. So here, we would not be able to tell endoscopically whether or not there was recurrence, and we would have to either extend the cut or ablate. But with confocal, we can see the cellular detail that is largely acellular in the scar versus glandular dysplasia from the confocal image. So to summarize, this is a colorectal cancer screening and prevention is a rare, happy story in the fight against cancer. Colorectal cancer is preventable and great strides have been made. Screening works, but is in need of process and technical improvements. But I think that we may see colorectal cancer largely eradicated in our lifetime. Thank you.
I love his dry humor. So dry as opposed to all the poop stories, which as a new father, I think I appreciate.
Yeah.
So fortunately, again, our next speaker I don't think has quite shown up yet. So we have a few minutes for Dr. Singh's questions for Dr. Singh. Heavily laden with the engineering side, so very interesting, yes. Speak up.
Assuming that you are do not have a high risk for colorectal cancer, assuming that you do not have a high risk and you start your colonoscopies at age 50, and then all your screenings after that indicate no precancerous polyps or anything, when do you stop? What
Yeah.
do the data indicate?
So this is an area of controversy and discussion. Ultimately, there's not data available for patients of screening above the age of 75. So that's the party line, is that you stop screening at age 75. But we have a lot of very functional people who live into their 80s and 90s. And you know, what's happening is as you age, your risk actually going up. And so we look at a case-per-case basis. We look at, first of all, the patient's willingness and desire to undergo continued screening. And you look at life expectancy. If their life expectancy is greater than 10 years, then it's perfectly appropriate to perform ongoing surveillance and screening.
So our next speaker is here, so I'm going to have to cut off any further questions, but I'd like us to all give Dr. Singh a warm round of applause.